first part of the lecture. So does anybody have any questions on the anatomy part of the heart? Okay. Are we good to get into the physiology part of the heart? Okay. Okay, so let's talk a little bit about the physiology. Okay. So we know that the deoxygenated blood, okay, that's high in CO2, low in oxygen, is brought back to the right side of the heart from the inferior vena cava and the superior vena cava, okay, which are the last two big veins. And then we already said that it goes from right atrium, right ventricle, lungs, gets rid of the CO2, picks up the oxygen, comes back to left atrium, left ventricle, goes out the aorta into the body, right? So this we went through already, okay? Again, the same thing, we're talking about the pulmonary side now, okay? Same thing, we're just talking the flow through the heart. Now, let's get into the different parts, okay? So the cardiac cycle is made up of two stages. We said systole, which is the contraction of the heart, and diastole, okay, which is the refilling of the heart. Now, most of the ventricles we said refill passively. Here they say 70, I said 75, but most of it is passive refilling, okay, caused by the AV valves opening up, okay, and blood just spilling from the atriums down to the ventricles, which is why we said people can survive in atrial fibrillation, okay, where they could not survive in ventricular fibrillation. Okay, so again, times we don't really care about, but basically you have, roughly have a heartbeat around every 0.8 seconds. Out of that 0.8 seconds, 0.28 of it is the contracting part, and 0.52 is the refilling part. So you actually take longer to refill, okay, than you do to contract. Okay, and the only reason I put that up there is that we're going to, not tonight, but maybe next session, we're going to talk about all the dangerous rhythms. And we're going to talk about tachycardias. Now, not sinus tachycardia that we all get when we're running, but we're going to talk about supraventricular tachycardia and ventricular tachycardia. What actually kills somebody when these very, very fast rhythms? We're talking heart rates over 150, 160, could be approaching 200, 300. So what kills them? What? Okay, no time for filling. It's called, very good, decreased ventricular filling time. So what happens? Your heart is going so fast that the time for diastole does not exist. The refilling part of the heart does not exist. So if you don't refill the ventricles, even though they're beating crazy amount of times, if there's nothing inside of them to pump out, you have no cardiac output, right? So that's the danger when somebody goes into a really, really super fast rhythm, is you have what's called decreased ventricular filling time. So you know one of the answers for the test that at some point maybe we'll take. Okay. Okay. So again, just telling us what happens. So we know to refill, okay, that the valves between the atriums and the ventricles have to open so blood can come down, and that the valves that are leaving the ventricles, either going to the pulmonary artery or the aorta, have to be closed. So the ventricles could now refill, and when you want to pump, the AV valves between the atrium and the ventricles have to close, and the pulmonic valve and the aortic valve have to open, so that when these squeeze, blood will go in the proper direction, okay? And this is showing you the superior vena cava and the inferior vena cava empty into the right atrium. Okay, and then off the left ventricle, you have your aorta, which then arches and goes down. This is the arch of the aorta, and here's the blood vessels that are going to go up to your head. Okay, so your carotids, your vertebrals are all off of this. Okay, you have your carotids in the front, your vertebrals in the back. Okay, all the blood vessels that are going to your arms, your shoulders, and everything like that are off of here. Okay, so now some terms. Stroke volume is kind of the same as tidal volume with breathing, right? So tidal volume was the amount of air we move in and out with one breath. Stroke volume is the amount of blood the heart pumps out with one contraction, okay? So the better your heart is, the better shape your heart is in, the more effective it moves blood. But approximately about 70 milliliters, 70 cc's of blood, okay, are pumped out with each one. You might have heard people who've had heart attacks, they talk about they have poor ejection fractions, where the amount of blood they can pump out is very low. And those are people that get LVADs, left ventricular assist devices and stuff like that, because they've damaged their myocardium by having a heart attack, and they can no longer effectively pump blood out. Okay, so it affects their stroke volume. And then we know what our heart rate is, okay? And again, they put 60 to 100. Most people are probably more towards 80 to 100, unfortunately, than 60 to 80. But the slower your heart rate, the better it is, okay? So now, if we took our stroke volume and times it by our heart rate, that should give us what we pump out in 1 minute, right? So we take how much with each contraction, which is the stroke volume, and times it by how many times our heart is beating a minute. It should give us our cardiac output, which is the amount of blood that our heart pumps out in 1 minute. Okay, so when I said somebody went into a really fast tachycardia, what happened? This number went from, instead of 100 to 200, and because of that, this number went which way? Down. So it ultimately affected this, all right? Now, what about if my heart rate went to 30? Okay, this number probably would go which way if it went to 30? What do you think? Probably actually goes up a tiny little bit, right? Because if you, because you have more time for filling. But the problem now is, you know who's best with this kind of stuff? Plumbers. Plumbers, you know, people that deal with things flowing through pumps are the guys that understand this, okay? So.
In the pump, though.
You're right, but we're going to talk about a second. You know when you stretch a rubber band, it snaps with more force? The heart is the same thing. You stretch the heart, it pumps with more force. So it's okay to overfill the heart. It can actually handle it as long as the muscle is not damaged. But that's a good point, okay? So when you have a slow heart rate, what changes is this number. This actually may go up to, say, 80, but if this drops down to 30, you're still going to have a decrease in cardiac output, okay? Not as crazy as when you have tachycardias, but you're still going to have enough of it. Okay, now, some other terms. Preload versus afterload, okay? Preload is the pressure in the ventricles at the end of diastole. So this is kind of what you were describing. In other words, how much blood is sitting in the ventricles pressing up against the walls. That's the pressure. So the more filled your ventricles are, okay, the more preload you have, which would generate more cardiac output because you'll be able to have more blood pumping out. But the other thing we have to think about is the afterload, which is the resistance that the heart has to pump against. So what's going to make it harder for the heart to pump out? What's going to increase afterload? What problem? What medical problem? Hypertension, high blood pressure. In other words, if the blood pressure in your aorta is very high, the left ventricle has to do what? Pump harder, okay? And what happens to your heart if every day of your life it has to pump harder than it's used to? What happens to that heart? It wears out, but what actually happens before it wears out? What disease do you get? Hypertrophy, okay? You get basically ventricular hypertrophy, which means the heart muscle gets thick. Now, we would all think the thicker the muscle, like when you exercise, the better it is. The heart is a weird muscle that the thicker it gets, the less efficient it gets, okay? And most people have a sudden V-fib arrest and just drop dead in front of you. They find out have ventricular hypertrophy. Okay, they could have something called prolonged QT syndrome. We'll talk about that when we get to it. But they could have ventricular hypertrophy. So what happened? For the impulse to travel through this thick muscle, it's much harder. It takes much longer because the muscle is so much thicker. And, you know, so we just recently in Curious Joel, they had a fantastic cardiac arrest save of a very young patient that was praying, and he just, boom, hit the ground. And, you know, the only thing that saved him was that there were 2 EMTs with a defibrillator present. And they shocked the guy. I don't know, it was 1 time, 2 times, I don't know. But they shocked him 2 times, and he reconverted and went into a normal rhythm because he had what's called primary V-fib, which means he didn't have a heart attack and go into V-fib. It just wasn't his lucky day. It was bound to happen because when they took him to the hospital and they did tests on him, they found out that his heart is about 3 times as thick as it should be. So he had ventricular hypertrophy. At some point it was going to happen. He had no idea, right? He didn't know, okay? And he was fortunate that it happened around trained people with defibrillators were able to put his heart back into rhythm. So now this guy basically has what? An implantable defibrillator in his chest, so if it ever happens again, the machine should be able to terminate it before it becomes lethal. Okay, so we understand the difference preload. So what would make preload change? What would decrease your preload? Yeah, well, it doesn't, I mean, shock can go, you know, you can't just say shock because you have to figure out why they're in shock, right? No, but that's just a stage of shock. In other words, really, what I'm saying is, you know, there's so many reasons. All shock is inadequate perfusion. If you could have a perfectly good blood pressure, right, could you be in shock? If you have perfectly good blood pressure, could you be in shock? Sure. If the blood doesn't have what you need, you'd still be in shock. So one day we have to talk about shock like in a little more detail, but you know, shock just doesn't mean blood pressure. That's a big misconception that a lot of people have, you know, in EMS, is that shock and blood pressure are the same thing. They're not. You have a perfectly good blood pressure and still not have the things inside that you need. The thing that's going to affect preload is the ability to get blood back to the heart, right? So if you're dehydrated, would your preload be less? Yes. If you have something interfering with the venous return to your heart, yes. So anything that interferes with the venous return to your heart is going to affect preload, okay? Or if the valves are sticky and they can't open up and you don't get that complete emptying down, it's going to affect preload. If you're an AFib and you're only getting 70% of your blood down, then you have 30% deficit in your ventricles of the blood that should be there. So that's why sometimes AFibbers when they go into a tachycardia, they get very hypotensive because they've already lost 30% of their preload down to their afterload. Now when their heart rate increases, they have that decreased ventricular filling time. So now you have two bad things, and it decreases their cardiac output, decreases the amount of blood that they could pump out. So that's, you could be an AFib, and as long as you're anticoagulated, it's fine. But if you go into AFib at a rate over 100, now you're going to start dropping your pressure, and you're going to start feeling weak and dizzy. Okay, now here's what we were talking about before, this rubber band theory. This is called the Frank-Starling law. So this, I guess, Dr. Starling, or whatever his name was, basically figured out that the more you stretch the myocardium up to a certain point, it will pump with more force. So a lot of times when people were having decreased cardiac output, we were afraid to give them too much fluid because we were afraid it would back up into their lungs. But he said the opposite. He said that if it's a right ventricular problem, give them all the fluid in the world, and you'll make the right ventricle pump with so much more force, and you'll get much more blood to their lungs. The only time you have to be concerned about extra fluid is if it's a left ventricular problem, because if the left ventricle is overloaded with fluid, it's going to back up into the lungs. So again, are we ever really going to know right-sided failure from left-sided failure 100%? No. But what would you see more with right-sided failure than you would see with left-sided failure? So if the right side of the heart is not pumping into the lungs, it's got to back up into the right atrium, then it's going to back up into the veins. So what would you see? Jugular vein distension. Remember, it is not normal to have jugular vein distension sitting up or standing up. If somebody's been lying down for a long period of time, you may get some mild jugular vein distension. Okay, but it's not normal. What else could you have when somebody has primarily right-sided failure? Okay, edema. So you get pedal edema if they're not moving around. If they're supine all the time, like laying in bed, where do you see the edema? You always see it on the dependent parts of the body, the lowest parts of the body. So you're going to see it where? In the sacral area, right? Back in here. You're not going to see it in the shoulders because that's touching the bed. You're not going to see it in the buttocks because that's touching the bed. So if you're examining a bedridden patient for edema, looking at their ankles probably is not the best place to look. You have to look for sacral edema, right? Back down in here would be the better place to look. So this is the concept of, that the heart can handle, unless it's had an insult, an injury to the myocardium, it can handle a little bit of fluid. Now the only other thing we have to talk about is what makes our blood pressure. Okay, so we had what makes up our cardiac output, right? So what makes up our cardiac output? We said it's our stroke volume, which is how much blood the heart pumps out with each contraction. And what else? How many times a minute the heart contracts, right? That's cardiac output. Now to make a blood pressure, we need cardiac output plus the pressure in the blood vessels, the pressure in the artery. Okay, and that's called your peripheral vascular resistance, okay? PVR. So can we measure PVR? No. I mean, not on an EMT level. In a hospital with special catheters, Swan-Ganz catheters and stuff like that, you may be able to measure pressures. But we have no way of knowing that, okay? Does your body know the blood pressure that's in your body right now? Yes, it does. How does it know the blood pressure in your body? We have special nerve fibers called baroreceptors, okay? And they're wrapped around certain large arteries, and they look at how stretched the artery is or how relaxed the artery is. So if the artery is very stretched, it thinks the blood pressure is what? High, stretched, right? It has to be a lot of pressure. So if it's dilated, pressure. If it's constricted, not enough pressure. In other words, it looks on how much force is being exerted on the artery, and it decides which way the blood pressure is. So if it doesn't see a lot of force on the artery, it says, uh-oh, the blood pressure must be low, and let me do certain things. Let me secrete certain hormones. Let me conserve fluid. Okay, maybe let me increase the heart rate. All the things that you learned that the body does to compensate when someone's in shock, the body knows to do based on those baroreceptors and the pressure that's on the arteries. Okay. So again, blood pressure is cardiac output times peripheral vascular resistance. So just real quick, let's go through the 4 categories of shock. Okay. You have hypovolemic shock. Okay. So that is low volume of fluid. What's getting affected? So we have heart rate, stroke volume, or peripheral vascular resistance. One of those 3 things has to be affected. So what's getting affected if your blood pressure is low, if your fluid is low because you're bleeding or you're dehydrated? Stroke volume. Stroke volume. Yeah. Okay, so now you have obstructive shock, okay, where you have a tension pneumothorax, so if you have a big emboli somewhere and blood flow is interrupted. What part of there is going to be interrupted? Still probably stroke volume, right? What else do we have? I'm sorry, I'm getting a little tired. What's the other ones? We have distributive shock, which is small blood vessels suddenly vasodilating, okay? So now, you didn't lose any fluid, okay? So the container gets bigger. So what part of the formula? Peripheral vascular resistance. The blood vessels dilate, okay? So the blood pressure drops because of that. It also drops a little bit because of preload, because of the amount of blood getting back to the heart, because when you dilate the blood vessels, what do you do to the blood in the body? You pool it. So not enough blood is getting back to the heart. So basically every one we could go back if you looked at cardiogenic shock, right? That's an interesting one because you have cardiogenic shock from muscle damage, you have cardiogenic shock from valvular damage, you have cardiogenic shock from rates that are too slow, rates that are too fast. So that could be almost any part of the formula, okay, except the peripheral vascular resistance, because that has nothing to do, the heart has nothing to do with the blood vessels. So, you know, you could go back and look at almost every form and tie it back to something in this formula. Okay, so now, going to our autonomic nervous system. Autonomic sounds like what? Automatic, right? So this is our nervous system that does not require us to be awake and thinking. This runs 24/7, okay, on its own, without any real influence, conscious thought influence. I mean, we could change things a little bit if we were awake, but pretty much it runs all on its own, okay? So that's your autonomic nervous system. So we have two components to our autonomic nervous system. Now you've heard this before. The sympathetic, which speeds things up, this is the gas pedal, and the parasympathetic, which slows things down, okay? So in EMT class, you learned the fight or flight syndrome, which means you were scared, okay, or threatened, and what hormone was released into your bloodstream? Okay, adrenaline, norepinephrine is the actual true hormone that's released into your body, okay? So this speeds everything up, this constricts your blood vessels, this does everything to prepare you for an emergency. Your parasympathetic is totally outside of this nervous system. This runs off of one of your cranial nerves, nerves that come from your brain to different parts of your body. This is your 10th cranial nerve, your vagus nerve, and this kind of slows everything down. So it slows your heart rate down, it dilates your blood vessels, so it basically relaxes things. If we got scared for no apparent reason and we recognize there is no emergency, our body would stop secreting the adrenaline, the norepinephrine, and start activating this one to what? Slow us back down, okay? The problem is that the epinephrine stays in our system for about 5 minutes, 10 minutes, so the effect doesn't stop immediately, but this is what kind of controls things. So just like when you're driving a car, it's constant gas, pedal, and brake, hopefully, right? This is the same thing. This is the same thing, okay? This is the same thing in your body, okay? So sympathetic, we have receptor sites. Now, this is a new term we're going to introduce because at some point we're going to start talking about how do heart rates get controlled and how do we, you know, how do we deal with things. Receptors think as a lock, okay? And something is going to go into a receptor and turn it, usually a drug or a hormone. So if you have sympathetic receptor sites, alpha and beta receptor sites, we already know the thing that goes there and turns it. We said it's epinephrine. So when epinephrine is secreted, it goes to these different receptor sites, I'm going to talk about in a second where they are, and turns something on. So if it's the receptor site is in your heart, what does it make your heart do? Beat faster, beat stronger, okay, pump out more blood, okay? So we have alpha receptors, we have beta receptors. We're going to go over all of these. Okay, they're in your heart, they're in your blood vessels, they're in your lungs. And most of the drugs we use on an EMT level actually stimulate certain parts of this. Now, a neurotransmitter, neuro like nervous system transmitter, it's very interesting. We know we're, besides tons of blood vessels, we're also tons of wires, right? Nerves going throughout our whole body. Those nerves don't actually go from point A to point B directly. There's synapses, there's gaps. I don't know why they were made that way. You know, we don't have one continuous run. I mean, we all sometimes sit there and pause for a second. I always say your synapses weren't firing, right? I mean, something wasn't working in the impulse, okay? But what bridges the space between two nerves is a neurotransmitter. It sends the same signal that the wire was across to the next wire and goes all the way through. And back in the days after September 11th, we were all given Mark I kits and atropine and all these different things, right, for a nerve gas attack, organophosphate poisoning. And one of the things that happens when you're exposed to an organophosphate, okay, anybody who's an exterminator, deals with pesticides, knows this is one of the dangers of their occupation. If you have too much of an exposure to it, it locks up, okay, those junctions and doesn't allow the impulse to stop. So if the impulse is constant, what happens? The body goes and has like a seizure-like activity, which is the late sign in somebody who has organophosphate poisoning. You learned in EMT class, right? Sludgem, salivation, lacrimation, urination, defecation, gastric motility, and meiosis. Those are the mild signs. As horrible as they sound, those are the mild signs. It's when you have the seizures and your muscles paralyzed and you can't breathe is what actually kills them. You've all exposed something to a nerve gas agent in your life. Did you ever take wasp spray or bee spray and spray a bee? What does it do? As soon as it hits them, what does it do? They fall to the ground, and what do? They twitch for a second and die. It's exactly what would happen to us if we're exposed to a weaponized nerve agent. They say the size of a pinhead would kill everybody in this room that quick, and to a weaponized version. Obviously, pesticide is not weaponized, it's not refined, but there are certain pesticides, insecticides that are very potent that could do the same thing. So you have to be very careful. So if you go on a call where, I know a lot of you are from Orange County, if you go on an agricultural call, and there's guys twitching out in the fields, and they tell you they're putting out pesticides, you have to be properly suited up before you go and try to take care of those patients, because this stuff could be a dust floating in the air, it could be liquid, it could be, you could breathe it in, it can be very, very, very dangerous. Okay, so again, we have alpha and beta receptors. We're going to talk about where they are. Our neurotransmitters, norepi, okay, and the adrenergic stimulation like adrenaline, okay, is what causes the heart rate to increase, and a new term, contractile force. Contractile force is how hard the muscle can squeeze, how strong the heart muscle is.
Could you go back to the parasympathetic nervous system?
We're going to go all over it in 2 seconds. We're getting to it. Okay, so we're doing sympathetic right now. Okay, so this is the sympathetic. This speeds everything up. Okay, now we're mainly going to talk about the heart, but when your sympathetic nervous system is activated, it in fact pretty much touches every part of your body. Because if you start with your skin and work your way all the way down, you know everything that happened. When your sympathetic is stimulated, what happens to your skin? Okay, well, let's talk. It does a certain type of sweat. It does a cold sweat. A warm sweat is always trying to get rid of heat, right? A cold sweat says what? That your sympathetic nervous system was stimulated. So why do you get a cold sweat? Because when you're scared, your blood vessels on the surface of your skin do what? Dilate or constrict? Constrict. So the warm blood no longer goes to the surface of your skin, okay? Now, we have hundreds, if not thousands, of little holes on our skin called pores. There's a muscle that opens and closes every one of those little holes, okay? When there's not enough blood going to that muscle, will it constrict or will it relax? Relax. So your pores open up, sweat comes to the surface, but it's a cold sweat because why? You don't have warm blood going to it. So from an assessment standpoint as a EMT or paramedic, a patient who has a cold sweat should go to the hospital unless it's explainable. Somebody calls to you and says, I felt dizzy, I felt weak, and I broke out in a cold sweat, deserves a ride to the hospital. Unless they tell you, somebody jumped out and scared me, or I almost got into a horrible car accident and I missed it by a second. That's explainable. The emergency's done. In about 5 or 10 minutes, they're going to be fine, unless they start telling you I'm having chest pain because I also have a cardiac condition or something like that. They probably don't need to go. But anybody else who breaks out in a cold sweat, there's got to be a reason why their sympathetic nervous system was broken out. So the skin gets cool, it gets pale, it gets diaphoretic. That's not normal. That's a cold sweat. Okay. What else happens? What happens to your vision when your sympathetic nervous system is stimulated? Better or worse? Okay. Certain parts change. Your pupils do what? Constrict or dilate when you're scared? Dilate, right? Okay, your pupils dilate. Why do they dilate? They want to let more light in if you're in a low light environment. Your peripheral vision improves, okay, when you're stimulated. So remember, this is fight or flight. This is back to like caveman days, right? The saber-toothed tiger is coming and you have to make a decision. Are you going to fight him or are you going to run? And this is all the stuff that kind of happened in the body. So you can go through it all different levels. Did you ever have to get up and give a speech at an affair, right? So they call you, you're talking, and what happens to your stomach? It starts growling, right? So, I mean, it's now, why does that happen? The body moves blood from non-important areas to important areas. So your skin's not important. It assumes that if you're going to get eaten by the tiger, you're not going to stop for a meal. So it moves the food from your digestive system to where? Where is it moving all the blood to? Your vital organs, and what else? The big muscles that are going to help you run or fight. Okay, so your stomach is deprived of blood, and then you get cramping. Okay, so you get this growling sound, you get the pit of my stomach type of sensation. So some of you probably heard this, but I had to speak one time at a hospital in the city on something, and I prepared. I really felt comfortable, and I walked into basically this lecture hall that was huge, and everything was wood, and there were pictures, 6 feet high pictures of all these famous people on all the walls, and it psyched me out. And I walked in, I was like, and I said, okay, don't do this, you're going to be fine. And I started preparing, and I could just feel the cold sweat building up and everything. I'm going, oh man, I'm going to blow this one like big time and stuff. So they're doing a sound check, and that was the other thing that intimidated me. I had all these people setting things up and putting like powder on your head because I was sweating and stuff. And they're doing a sound check, and all I hear in my stomach is going, and I'm going, the mic must be picking it up and everything. So the doctor that invited me to come and speak came in, and he's like, you okay? And I'm like, do you have a Valium and a beta blocker? And he's like, what? I said, my heart rate is about 150, and I'm so nervous that I can't even hold my hand straight. He's going, oh, you're going to be fine, don't worry about it. He goes, pretend they're all in their underwear. I said, yeah, people said it all the time, it's not going to help and stuff. So that was all sympathetic, stimulation, that was going on in my body right then and there. Okay, so now going to the parasympathetic nervous system. So the neurotransmitter is something called acetylcholine, okay? And again, the nerve engines are not adrenergic, but cholinergic, okay? And this slows everything down in your body and relaxes your blood vessels. So it slows down the SA node of the heart, it slows down the AV node of the heart. We're going to talk about all those in a second, and it relaxes everything and slows it down, okay? So, I don't know what page it is.
Oh, okay, got it.
Okay. So, again, let's just quickly review. Adrenergic, okay, is the sympathetic, speeds everything up, okay? Epinephrine that we learned, really it's norepinephrine, but that's fine, speeds everything up, okay? A receptor is a site that responds to these different neurotransmitters. So think of it as the lock and the neurotransmitters as the key. And when the two of them meet, something happens, okay? If it's a sympathetic, things tend to speed up. If it's a parasympathetic, things tend to slow down. Okay? And again, cholinergic would be the parasympathetic, adrenergic would be the sympathetic. Receptor sites are present on both of these. Okay? I thought it had more on parasympathetic, but I don't see it. But going back to parasympathetic for 1 second. The sympathetic is a huge response throughout your whole body. Parasympathetic has the ability to be isolated to certain areas. Now, you've all heard of vasovagal, right? What's vasovagal? What does that mean? It means that you were scared, you saw something that bothered you, like blood or bad news, and what happened? The parasympathetic was activated. Your 10th cranial nerve, your vagus nerve, got activated, and it jammed on the brakes on your heart rate, and it vasodilated your blood vessels. So if you jam on the brakes of your heart rate, remember your cardiac output, right? So you're slowing your heart rate, and you vasodilate your blood vessels. What has to happen to your blood pressure? Down. And if you're standing upright, what has to happen to the perfusion to your brain? Down. And what has to happen to you? Right. So we have people that vasovagal all the time, and whether or not they're hurt depends on if they hurt themselves when they fell. If they fell backwards into their bed, they feel weak, they feel terrible, okay? But they're probably not injured. So one of the things we always have to assess people for is there a traumatic component to it? In other words, did they hurt themselves did they face plant? Did they do something like that when they vasovagaled themselves? Now, what causes people to vasovagal? It could be bad news, it could be blood. When I used to teach a paramedic class at Westchester Community College, they sent me to the Westchester Medical Center for blood work, as a pre-employment physical. So I walk in, and there's this lady who said she had been there for 100 years drawing blood, and she looks at me and says, "You're a fainter." And I said, "What are you talking about? I'm a paramedic, I draw blood all the time." She's like, "Honey, I've been doing this for years, you're a fainter." So she basically puts me in this chair, straps me in, I'm like, this is totally unnecessary. Shut up, sit down, be quiet. And I remember the needle going into my vein and the blood splashing up into the vacutainer. Next thing I remember her going, "I told you." And I'm like, "You psyched me out." And she's like, "Orange juice." I'm like, "Shh, be quiet, don't let anybody know, And they made me lay down and everything like that. And I'm like, "Please don't tell anyone, it'll be so embarrassing." But boom, I just remember watching the blood splash up into the vacutainer and then out cold, and laying there, with her smacking me in the face, making fun of me and stuff like that. So that is one way you have vasovagal. But what are some other ways that you could have vasovagal?
Sudden position changes?
Sudden position changes is a little bit different. What you're talking about is like, what?
Orthostatic.
Right, so that's a little different. So it's probably not that your parasympathetic nervous system is activated. It means that you are in a relaxed state. So here's how it happens. You're in a warm bathtub, hot tub, jacuzzi, and the warm water causes vasodilation, and you're relaxed. You're having a good time. And now, I don't know, there's a shark in the water, and you jump up. Okay. So one more great story. Does anybody know Ray Culver? Anybody remember Ray Culver? Ray Culver was my old partner for many years. We go to the one convention I ever went to in my life, and we go down to the hot tub that was like, a 50-person hot tub, and there's not a square inch of space. So I said, I guess we're not doing this tonight. He goes, partner, don't worry about it. And he walks over and starts going, I heard hot water is really good for my sores. And he takes his leg and he dips it over this guy's head. So basically his crotch is sitting on this guy's head. And he says, oh, water feels good. And this guy shifts over a little bit and he goes, yeah, the scabs are coming off and the place cleared out like the Red Sea. And he goes, now we have it to ourselves. And I said, okay. So I said, you don't really have anything on you, do you? He goes, no, I just did that to, get everybody out of the water. So, but that was my good Ray Culver story, amongst many other ones. But we'll tie it into different parts of the lecture. So he's retired in Florida somewhere now, living the good life. Okay. But anyway, what you're describing is, it could happen when the hot water you suddenly get out. It could happen when you're sound asleep, right? So you're sound asleep, your heart rate slows down, your blood vessels vasodilate, and now your kid screams out for your mommy or daddy, and you jump up out of bed. So it's just related to your heart rate's slow, your blood vessels are dilated, and you jump up into a standing position, okay, and your body doesn't have enough time to compensate, to increase your heart rate and clamp down. You lose your perfusion to your brain, you fall down. But it's not that your sympathetic nervous system was directly stimulated, and that is the culprit.
I said the common one is people stressing themselves when they're doing the number 2.
Yes. Okay, so you're going to the bathroom and you're a little constipated, okay, and when you go, I don't want to do too much, but one of two things could happen. I could vasovagal, or it could get a little messy. Okay. Oh, we're getting taped. I got to remember. I got to remember. This was always my problem in class. Yes. My biggest fear is that my wife will one day listen to some of these tapes, so I'm really being good about no wife jokes tonight. But anyway, going back to that, when you bear down, you increase what's called your interthoracic pressure in your chest, and that's one way you could stimulate the vagus nerve. Good, so that's a good way. Okay, the back of your throat. So your vagus nerve runs from your brain all the way to the back of your throat. So when we do airway procedures, especially in children, we could cause them to vasovagal, which is why we're supposed to not insert an oral airway the regular way in kids, right? We're supposed to use the tongue depressor and put it in back that way. How many ambulances have tongue depressors? Really?
Finger splits.
Okay. Well, most of you didn't hold up your hand. Okay. So years ago, it was Part 800 in New York State to have 12 tongue depressors. Okay. But it's not anymore. So, but yes, the back of the throat would be another way, okay, that you could stimulate it. So, blood, bad news, increased interthoracic pressure, okay, stimulating the back of the throat are all different ways that you could stimulate it. And that's all going to cause a slowing down and a vasodilation, which is going to drop the blood pressure, which is going to decrease the perfusion to the brain, which is going to cause the person to syncopize, okay? So now we're looking at the different receptors. So you have alpha receptors, beta 1 and beta 2. Now they have that there's alpha receptors in the heart. I've never heard that before. So I don't know. I looked it up today and I didn't see that. So I think we're going to cross this one out. But where you really have alpha receptors are in your blood vessels. And when alpha is stimulated, remember when something that norepinephrine goes to the alpha receptor sites in your blood vessels, it causes vasoconstriction. Okay? So alpha stimulation of blood vessels, if you want to write next to it, vasoconstriction. Okay? I'd cross this out. It has no effect on the lungs. Beta 1 stimulates the heart to beat harder and faster. Okay, if you want to write next to it. So beta 1, heart, harder, faster. Okay. Alpha in the blood vessels, vasoconstriction. Beta 1 in the heart, harder and faster. Okay. Harder means contractility. We talked about that term contractility before. And then beta 2 is in your lungs. Now, somebody impress me and tell me what beta 2 medication are we allowed to administer as EMTs? Albuterol. Excellent. So albuterol is a primarily beta 2 drug, okay, that will cause bronchodilation. So when beta 2 stimulates the lungs, it causes bronchodilation, okay? And beta 2 in the blood vessels causes vasodilation. Okay, so let's review them again. Alpha on blood vessels causes vasoconstriction. Beta 1 on the heart causes an increase in heart rate and force, which translates into more blood getting pumped. Beta 2 in the lungs causes bronchodilation, and you could write equals albuterol. And on the blood vessels causes some very mild vasodilation. Now, do we have a drug that takes care of alpha, beta, and beta 1 and beta 2? Do we carry a drug that does all three? Very good. Epinephrine. Think about it. We give epinephrine in anaphylaxis because in anaphylaxis, a couple things killing them. They have vasodilation, so epinephrine will cause vasoconstriction and take care of the vasodilation of the anaphylaxis. And we have bronchoconstriction, and it'll cause the bronchodilation. So that's why we use epinephrine. Okay. So a lot of the drugs that we'll go over at some point, you can tie back to all these different receptor sites in the body that are going to be stimulated, and that's why we're giving them. Sometimes it has an adverse effect. In other words, we didn't want it to happen, and it happens. Like when we give nitro, we get some vasodilation. That's not why we give nitro specifically, okay? Well, I shouldn't say that. We do give nitro to have vasodilation in the coronary arteries. We just don't want vasodilation throughout the whole body and dropping the pressure. Okay, so we'll talk about all those as we go on. So again, vasoconstriction, which causes increased blood pressure. Beta 1, increased heart rate, increased contractility in the heart. Beta 2, bronchodilation and vasodilation. Okay. So these all sound like very good but meaningless test questions. So those are always good to put on the test. Okay, so any questions on the second one? So you want to take 5 minutes, stretch your legs, use the bathroom, get a drink, and then we'll come back and do. I think we got. This is also what's going to cause the pale skin on the surface because it's vasoconstricting certain blood vessels to drive more blood to more important ones. Okay, so like on your skin, you're going to have pale skin, but your muscles and your legs are going to get a lot of blood. Your lungs are going to get a lot of blood. Your heart is going to get a lot of blood. Okay, beta 2 causes the heart rate to increase and the strength. So this also causes an increase in blood pressure. This, and this all increase the blood pressure. The beta 2 we don't notice when we're scared. We don't notice that when we're scared it's easiest for us to breathe. But we always, when we're scared, we have some bronchodilation because if we're running and fleeing, our lungs have to be more dilated so we can get in more air. Right? But we don't notice that. We don't notice that it's easier for us to breathe. In fact, by the time we finish running, we're huffing and puffing and we feel like if anything we're having more trouble breathing. Okay. Actually, this is interesting too. When women are pregnant, there's certain hormones that are secreted in higher levels than normal. And one of the hormones causes bronchodilation in the woman that's pregnant. Why? Because when she has this baby in her third trimester that's pressing up on her diaphragm, it becomes pretty hard to breathe. So again, she doesn't know that. It's still hard for her to breathe. But if it wasn't for that bronchodilation, it would be much harder for her to be able to breathe. Okay, so is it okay? Is the alpha and beta receptors okay? Okay. Okay, so now we're going to get into the electrophysiology. Okay, so you learned in EMT class that there's different types of muscles in the body and that the myocardial muscle is a special muscle only found in the heart. That muscle has special cells called myocardial working cells, okay? And those are the cells that basically have the ability to initiate their own impulse to beat. They do not need the brain to tell it to beat. The brain can influence it because we already said the parasympathetic nervous system can slow things down. That's one of the cranial nerves. And if you perceive danger, your brain would signal your sympathetic nervous system that the tiger's coming, and then your heart rate would increase. But on its own, without any stimulation from the brain, your heart will beat, okay, 60 to 100 times a minute while you're sleeping, okay, with no problems whatsoever because of the fact that the heart has the ability to initiate its own impulse. The lungs, on the other hand, don't have the ability to breathe on their own. The lungs require stimulation, control from what? The brain, right? The brain tells, the brainstem, your medulla, tells your lungs to work depending on the level of CO2 in your body. If it's too much CO2, you breathe more. Too little CO2, you breathe less, okay? That still works when you're sleeping. The difference is that when you have a brain injury, the brain will no longer work and you have to be put on a ventilator, but your heart will continue to beat. So you have somebody who's, quote, a brain dead. They're on a ventilator being kept alive. They're being fed, artificially. Nobody's talking about managing their heart. There's no pacemaker on the patient telling the heart to beat. It's because the heart itself has the ability to initiate its own impulses, okay? So when the heart has this impulse that causes it to contract, okay, and it pumps blood, just like we were talking about before. So we're going to talk a little bit more as we get on what these cells need to work, but you already know one of the things they need is oxygen, right? They need sugar, okay? We're going to get into certain electrolytes like potassium and sodium and stuff like that, and calcium that the heart also needs. The other day I was teaching, I think in Greenwood Lake, and we talked about these ultra athletes, right? These people that run marathons. If you ever volunteered to work at a marathon, they do very good training, because one of the things that happens when you're in such good shape, okay, and you drink too much during the race. So think about it, I'm in phenomenal shape. You know, I'm not, but I'm saying I'm in phenomenal shape. I'm running a marathon, which hasn't happened since I'm 14, okay? And now I stop at every water station and drink. What am I going to do to my body? I'm going to drive what too low? My sodium and my potassium. And then these guys die from what? They go into VFib, but it's not VFib the way we think of VFib. It's VFib what they call a hyponatremic, low sodium VFib. So all the shocking in the world, all the drugs in the world will not reverse them, because what do they actually need? Sodium. So it's very interesting where they actually discourage them, okay, from drinking. And we were talking about heat emergencies, and we're saying that sometimes in our desire to be helpful, we're actually harmful. So we get somebody who has, you know, severe heat exhaustion, and they're cool, they're laying there, they're, you know, oh, I feel terrible, I can't lift my head, you know, and you know they're profoundly dehydrated. You come and give them water. Now what happens? When they sweated, right, when they were sweating, what did they lose? Not just fluids, but they lost sodium, potassium. You give them straight water with no sodium, potassium in it, you're actually doing what to their level of sodium, potassium in their body? Driving it lower. So, you know, we have to think about that before we just go and, you know, start treating people what's wrong and how do we fix what's wrong, not make it worse. Okay, so again, the heart has these special pacemaker cells. They don't contract, but these are the ones that set the rate and rhythm, and this is what we're going to talk a lot about tonight. And this is when we talk about your cardiac conduction system, what actually initiates the impulses, okay, for the heart to be able to beat. And what's interesting is there's redundancy built into our system. So if our primary pacemaker site fails, we have a backup. And even if the backup fails, we have another one. So that we're kind of like NASA with the space shuttle, where there's numerous redundant systems, okay, designed to keep us going even when the primary pacemaker fails and the secondary pacemaker fails. Okay, so just a couple terms. The threshold means something has to reach a certain point for something to happen. So when you're initiating these impulses, these electrical impulses, they reach a certain point, nothing happens, but then when they go beyond that point, the heart is stimulated. And you'll see as we go on what that means. And this all or nothing phenomenon means that if one myocardial working cell depolarizes, the whole heart will depolarize. So it only takes one cell, like the little engine that could, one cell to work, and then the whole heart will work. Okay? So if the SA node fails and some cell in a general area starts to work, the heart will still contract. So it's pretty hard, actually. You know, we do our best, but it's pretty hard to kill your heart, okay? And as long as you're feeding it well and taking care of it well, it really does work pretty well. Okay, so some terms we talked about before. Contractility refers to mechanical force, the squeezing of the heart to pump blood out, okay? Automaticity is the ability, the ability for the heart pacemaker, the cardiac pacemaker sites to initiate an impulse. Okay, and the reason we're bringing this up, that later we're going to talk about things that interfere with contractility, things that enhance contractility, things that interfere with automaticity, things that enhance automaticity. So if you interfere with automaticity, the heart will beat slower. If you increase it, the heart will beat faster. Excitability, again, is the ability for these impulses to move all across. And when we talk about SVTs, excuse me, when we talk about SVTs, we're going to say sometimes the heart is irritable, it's cranky, okay, and it over-responds, and it starts going out of control with these tachycardias. And the conductivity is the ability for, again, for the impulse to move from one cell to another cell to another cell. And we're going to talk about how it plays a role as we go on, but the sodium, potassium, and everything like that does play a role. Okay, so we talked about these electrolytes. Okay, and electrolytes basically are substances that have a little bit of an electrical charge. We're not going to get into it too great or anything like that, but just to understand that to be able to have a cardiac impulse, you have to have an adequate amount of potassium, an adequate amount of sodium, and an adequate amount of calcium. Now, what medication can our elderly patients be taking to control their blood pressure that may screw up their potassium? Diuretics, right? You'll notice that most people who are on diuretics are taking a medication with a K, which is potassium, the chemical symbol for potassium, or they're told to eat bananas and stuff like that. So if you go there and their complaint is I'm weak and dizzy and feel like I have no energy, probably the culprit is they're not getting enough potassium in their body. And that's what's causing them to feel weak. That's the early sign of a low potassium level. As it gets worse, it would interfere with their ability for the heart to work. They may get muscle cramps from lack of potassium, okay? Just like when somebody has, you know, heat cramps, they're getting muscle cramps. It's related to, again, not enough potassium and sodium and stuff like that in their body. Okay, so we have a sodium-potassium pump, believe it or not, in our body, in our heart. And what it basically does is pump potassium in and then pump sodium out. And the changes of the movement of sodium and potassium generate a slight electrical charge, and that's what starts the whole cardiac conduction system. Okay? So that's really how everything works, by the movement of these electrolytes in and out. The reason I bring it up is I want you to recognize how important it is to have an adequate amount of these electrolytes in your body, and when our patients don't, what could go wrong? I mean, who would think that somebody who is in great shape, exercising, and now a little dehydrated, over drinks and throws themselves into VFib, and then we're wondering why we're shocking him 8 times and nothing's happening? Because he didn't go into VFib for the regular reason. His problem is he doesn't have enough potassium and sodium, and we're going to shock him till we stop his heart and put him into asystole, and then we're going to pronounce him dead because we can't fix him, okay, unless we have the ability to return that potassium and sodium to his body, which on a BLS level we're not, and even on an ALS level, you know, we don't carry potassium. I mean, we do have normal saline. It's not a whole lot of sodium, but we don't carry potassium. So probably this guy now, when you do these marathons, they have special teams set up with all the things they need to administer these patients because they recognize what it is. But the average patient, we wouldn't have anything to be able to do. The only other time you're going to see a problem with a electrolyte is if you deal with a place where patients are on anti-psychiatric medicines, like we have Rockland Psych down in Orangetown, right? I'm talking heavy-duty dosages. Sometimes these medications increase their thirst mechanism where they always feel they're thirsty. If you ever go into a real psych hospital, you'll notice that there's no faucets. The handles are missing from the faucets on the sinks, and they use a key to open and close the faucets. The toilets are all locked because these people are so thirsty that they will actually go and drink and drink and drink, and then what will happen? They'll drive their sodium potassium down. We typically get them as a seizure, okay, and then we come and give them the normal drugs we give to stop a seizure, and it doesn't stop the seizure. Again, just like we couldn't stop the VFib, we can't stop the seizure because the seizure is a hyponatremic seizure. So, you know, but it doesn't happen. You know, nowadays it doesn't happen as much because the newer medicines don't have that problem. Okay, so again, so the sodium potassium pumps in and out. Everything happens like it's supposed to, okay? And we get this cardiac depolarization. Depolarization means the muscle is charged and it squeezes, okay? And then when it rests and get ready for the next one, it's called repolarization. So depolarization is the squeezing, the pumping part of the heart, what we would call systole, but this is from the electrical. Depolarization is talking about electricity. The systole is the mechanical squeezing. So depolarization has to happen to make systole, the pumping of the heart. And then when the heart is I don't want to say repairing itself, but getting ready for the next one, it's called repolarization, okay? Did you have something?
No.
Okay. So how fast it takes everything to contract, we don't really care about, but the atrial muscle takes about 0.15 seconds because it doesn't really have to do much. It's a very small muscle. And the ventricular muscle about 0.25 to 0.3 seconds. Okay, and then rest is called repolarization. So activity, electrical activity causing the muscle to contract is depolarization. When the muscle is resting, getting ready for the next beat, it's called repolarization. Okay. Now, we have 2 stages we need to talk about, and we're going to start next lecture getting into actual EKGs. So right now, these don't mean anything to you, but just so you know, this is something, the first little bump is called a P wave. That's when the atriums are contracting. This is your QRS. This is when your ventricles are contracting. And this is when everything is getting relaxing, okay, and getting ready for the next beat. So the next beat is going to happen someplace off to the right. So what they're showing you here is they're calling something called the absolute refractory period. What they're saying is that absolutely another impulse cannot happen right now because the heart just did what? It used up its sodium potassium, it contracted, it's spent. It's like when you're exhausted, it's spent and it's recharging. But what you notice is that this period stops in the middle of the T wave, which tells you that on the downslope of the T wave, we have what's called a relative refractory period, which means that the rest period is almost done. The heart is getting ready for its next impulse. And the reason I bring it up is that this is a very dangerous period. How many of you heard the story of the kid on the ball field and gets a line drive to his chest and drops in VFib? Okay, so why does he go into VFib? What happened? So not only was he not lucky that he got hit with the line drive hit him on this part of his heart complex. The heart is now rested and getting ready for its next impulse. And that drive to the chest, believe it or not, that little kinetic energy that when that hit his chest generated a couple millivolts of electricity. You wouldn't even really feel it, maybe like a little static electricity, but it was enough to stimulate his heart to beat before it was ready to beat, and they tend to go into VFib. And this is really why AEDs are in schools. There was a kid in Long Island, this exact story happened to him. He dropped to the ground, the school didn't have an AED, the police did not have an AED, the ambulance didn't have an AED, and the kid died before he got to the hospital. And his parents, as part of their grieving process, lobbied, when they found out there was a device that could have saved this kid, they lobbied to pass a law in New York State that schools had to have AEDs. And that's why, whatever it was, 15 years ago, 20 years ago, AEDs were put into schools. Okay, so again, this stage, the ventricles have contracted. That's the main part of your heart, right? That's the main muscle of your heart. The heart is used up. It's resting, getting ready for the next impulse. The sodium potassium's equalizing itself out, okay, getting ready. The dangerous part is the downslope of the T wave, okay? This is when the heart is almost ready to beat again. And if something happens there, we can throw a patient into VFib. And we're going to talk about this time and time again when we get into talking about the lethal rhythms, the VFibs and the VTACs and stuff like that. So does everybody understand the difference between these two? Does everybody understand the difference between depolarization and repolarization? So depolarization means what? The electrical impulse is firing. Think about if you shocked yourself and you twitched. That's basically depolarization. The muscles did what? When you apply electricity to a muscle, what does it do? Contracts. So what's contracting? Your ventricles, right? So that's depolarization. That generates systole, right? That's the mechanical part of depolarization, the pumping of the heart. And then when it's relaxing, it's repolarization. The muscle's relaxed, it's refilling. That's diastole, getting ready for the next one. Yes? Too late? Everybody got a lot of blank looks. This is important, or else I wouldn't go over it 5 times. Yes? Good? Okay. Okay. Okay, so that was this lecture. We're going to go on and get into a little more harder stuff. I know it's not good to do the harder stuff as we get later into the night, but we'll try one more. We actually got 2 more lectures, but we'll try one more if we can get all of them in. That would be great. If not, okay, so now we're going to talk about the electrical conduction system, right? We're going to talk about all these different terms. Now, I know this is like a new language, right? Some of you maybe never heard of these terms, so we'll go nice and slow. You have your handouts, okay? I'm going to send out, hopefully, as soon as we get the email list, a link to a website that has some very, very good review material on it, okay? And if between now and the next class you have a few minutes, you can go through some of this stuff. It'll tie it all together. My phone number is on the handout. So my email address is on the handout. So if you have any questions and you want to shoot me an email, I'll definitely try to get back to you as quick as I can. If it's something that I can't answer by email, I'll just shoot you my phone number and we can talk. Okay, so we're going to talk about how everything goes through the body. Now, I think I gave you this as a separate picture because I wasn't sure how it was going to come up and how well everybody would be able to see it. So basically, your conduction system starts with a special bundle of nerves high up in the right atrium called your SA node, sinoatrial node. That is what we're going to call the dominant pacemaker of the body, okay? Now, if you notice, there's pathways that go throughout the right atrium, but there's also a branch called the Bachmann's bundle that goes over to the left atrium, okay? So when the heart depolarizes, typically what happens? The atriums push blood down to the ventricles, and the ventricles pump blood out to where it needs to go, okay? So both atriums are going to fire. That's going to give you your SA node, okay? The impulse is going to come down to this little area right over here called your atrioventricular node. This is your backup pacemaker. Now, when they talk about a pacemaker, they're saying that this little device of nerves was designed to fire, I shouldn't say nerves, this little bundle of cells, specialized cells, is designed to fire about 60 to 100 times per minute. How do we know that? Because that's our normal heart rate. So this is your dominant pacemaker, and this is designed to fire 60 to 100 times per minute. Can it go less? Yes. Can it go more? Yes. But it's always going to be because of stimulation from one of those neurotransmitters. If it's the vagus, right, the parasympathetic, the acetylcholine, it's going to go slow. If it's a sympathetic, the norepinephrine, it's going to go fast. But on its own, it's going to beat 60 to 100 unless there's some other innervation, some other stimulus from it. Then it's going to go down to the AV node, okay? And this is going to beat around 60 to 80 times per minute, okay? And then it goes down. Now, this is that septal wall that we talked about. This is the wall that divides the right and left side of the heart. You see how once it gets out of the right atrium, this is the bottom part of the right atrium, this is the upper part of the right atrium. Once it got out of the right atrium, it goes into it ties together into a little bundle of His, okay? And that bundle of His goes into the septal wall, and then what does it have to do? It has to split to go to the right atrium and the left atrium, okay? And those are called your bundle branches because there's two bundles. Your last pacemaker is in the ventricles itself. So if everything above fails, the ventricles will beat at a rate of 20 to 40 beats per minute. Not enough that you're going to run a marathon, but enough that you may stay alive long enough to get help, okay? So if the ventricles get no stimulation from above, they will actually start firing on their own. It may not mean your atriums are firing, but your ventricles are firing. We already said that most of the blood that comes from the atrium to the ventricles comes by gravity, so it's not great not to have your atriums contracting, but it's not lethal not to have your atriums contracting. Okay, so now we're going to go over it again a little slower. So sinoatrial node, okay, is high up in your right atrium. It's the primary pacemaker of the heart. It's set to beat 60 to 100 beats per minute, okay? And when that happens, the atriums depolarize, okay? So again, it fires from here. These three branches, okay, these internodal tracts, are for your right atrium, and then you have the bundle, Bachman's bundle. I know it looks like it's just one, but obviously it splits into many, and that causes the depolarization of the atriums. That generates the P wave, okay, which was that first upright, rounded complex on your EKG. Okay, and we're going to go over it again. Your intranodal pathways are these pathways inside the atrium to make sure the entire atrium contracts, okay? And then we had that one special bundle that went over to the left atrium called your Bachman's bundle, okay? And that helps to bring the impulse now from the SA node down to the next pacemaker, which is your AV node. So it comes from here down to your AV node, okay? Again, Bachman's bundle is the one that goes to the left atrium, okay? And it's a branch off of your internodal tract that's in your right atrium. Okay, so again, this is going to bring the impulse from your right atrium, from the SA node in your right atrium to your left atrium to make sure that depolarizes. So we talked about this being a dominant pacemaker, 60 to 100. When this fires, your atriums depolarize, okay, and this causes the P wave on the EKG complex. Okay, whoops, I went too far. Okay, so next one is your atrioventricular node, and that is down at the bottom, okay, of your right atrium. Okay, that's your backup pathway pacemaker. Okay, now here it's very interesting. The impulse is actually delayed for 0.5 seconds. Now, did we have an actual EKG on this anywhere? No. Whoops. That's in case you're sleeping. Okay, so if you ever look, there's a P wave and then there's a little bit of flat line before there's a QRS. That flat line is this pause. Now, why is there a pause? Between the atriums contracting, okay, and the ventricles contracting. Exactly. You want all that passive flow of blood to come down. So that little pause you see is allowing the atriums to fully spill whatever is left after the contraction down into the ventricles. Okay, so whatever blood was left is going to come down in that little 0.5 seconds, 0.05 seconds pause. Okay, so it allows for the ventricles to completely fill. Okay, and then we have this little structure called the AV junction, which you really don't see well, but it's kind of right over here, right before the bundle of His. Okay, no big deal. It's basically just where the AV node joins to the bundle of His. Okay, so it's not a big deal. This is where our secondary pacemaker is. So some people say it's in the AV node, some people say it's in the AV junction, but just remember AV. It's your backup pacemaker, your secondary pacemaker, 40 to 60 beats per minute. Okay, so if your primary pacemaker fails, this is the one that will take over. what would be missing on your EKG complex if the AV node was a dominant pacemaker? What wave would you not see? The P wave. So these are called junctional rhythms, i.e. the AV junction. So instead of being sinus rhythms, sinoatrial node, which is a normal rhythm, these are called junctional rhythms, and they usually have an absent P wave, okay, or an inverted P wave. So most P waves are upright. It may have an inverted P wave. And when we get into looking at all the different EKGs, I'll explain why it happens. Okay, so after it goes through the junction, the AV junction, it goes down into the bundle of His. Again, this goes through now the intraventricular septum, which is the wall between the atriums and the ventricles. Okay, and this is going to bring the impulse now down into the ventricles, which obviously is the important part of the heart. So the bundle of His splits into the right bundle branch block, which goes to, right bundle branch, which goes into the right ventricle, and the left bundle branch, which goes into the left. Okay, and then off of these bundle branches, let me see if I have another one. Off of these bundle branches, you see these little hair-like projections down here? Those are the little tiny nerve fibers called the Purkinje fibers that basically innervate, go all through the muscle of the myocardium, so that when the electrical impulse comes down there, the entire myocardium as one piece contracts. Like, you don't want little spots in the myocardium. You want that whole muscle as one thing to squeeze at the same time. Okay? And that's your backup, your Purkinje fibers are your backup pacemaker in the ventricles, that if they get no stimulation from anything else, they will fire on their own at a rate of 20 to 40 beats per minute. Okay? Have you heard of a complete heart block or a third-degree heart block? Right? So in a complete heart block, what happened is, right here, something failed, like this wire was cut. So nothing from up here is getting down to the heart. It really isn't cut. It's a kind of a fake wall that's developed there. But it could be as if it's cut, so no impulses are coming down. So what happens? The ventricles say, I'm waiting, I don't get stimulated, fine, I'll do it on my own. They only beat 20 to 40 beats per minute. In what position do we now find our patient that's in a complete heart block? Supine, right, or face down, prone. And they say every time they try to lift their head, what happens? They pass out. Why? The heart is not beating enough times per minute, so their cardiac output is